I'm Vince Gennaro, the Associate Dean of the Tisch Institute for Global Sport at the NYU School of Professional Studies. And one of the most important things we do in our education of students is to help them develop and enhance their critical thinking and problem-solving skills. Critical thinking is really about rational decision processes and empathy. On the rational decision processes end, it's about being able to counteract and tease out natural biases we all have. It's about separating objective from subjective information, analyzing data, and integrating it into decision processes. On the empathetic side, it's being able to look at a problem from a different point of view, from a point of view someone else may hold, and maybe one that doesn't come so naturally to you. And in order to illustrate this and demonstrate it, I've chosen the issue of the day, which is COVID-19, in something I'm calling the calculus of COVID-19, assessing the risk of reopening the economy. So let me walk you through this short PowerPoint, really as an example of the process of critical thinking. In processing through this issue, I want to start with an assertion that some have made that COVID-19 is similar to a bad flu year or a typical flu year. If we look at the data for 2019-20 flu season, there's been a wide range of estimates, but the midpoint of those estimates is about, by the CDC, is about 47.5 million infected with the flu this year and 43,000 deaths. That's a death rate, deaths divided by infected, of just under 0.1% or 0.091%. Conversely, with COVID-19, as of April 24th, we had about 900,000 reported infected cases, with deaths of about 50,000 here in the US, for a death rate of a little over 5.5%. And that death rate, note, for COVID-19 is about 61 times the death rate of the flu, according to the reported data. Now, however, I think it's reasonable to assume that the reported numbers for COVID-19 infections are less than the actual. In fact, some preliminary results from a survey released by New York Governor Andrew Cuomo recently suggest that as many as almost 14% of the residents of the state of New York are carrying antibodies, implying that they've either had the virus or been exposed to it in some capacity, even if they were asymptomatic. So these results suggest that perhaps 2.7 million New York residents, this is New York State now, have been infected, which is approximately 10 times more than the reported 275,000 cases of New York State people with the virus. So if we assume the reported deaths are accurate, the reported deaths are accurate, but that the infections are significantly underreported, then perhaps the death rate is much lower than 5.6% of reported cases. So let's just use, for example, the New York State numbers and gross up the US numbers for those that in fact may be infected. That would suggest that instead of 900,000, there's 9 million people infected, and therefore the 50,000 deaths would be a 0.56% death rate. That's actually, instead of 61% more or times the flu, it's only 6.1 times the death rate of the flu. However, so even if we agree that there's a considerably higher death rate of the flu, that's not where the story stops, because the lack of a vaccine would mean that we would have significantly more, likely to have significantly more COVID-19 infections than the typical flu. So when you look at the flu vaccine and the nature of that virus, we typically have an infection rate year to year of less than 20% of the US population. But in the absence of a vaccine, it's estimated that herd immunity in the US, the point where COVID-19 would stop spreading, is somewhere between 55% of the population and 82% of the population being infected with COVID-19. Now, the midpoint of that range is 68% infection rate. And before we get into that, let's look at a little bit about what herd immunity means. It means that in the early stages over here on the left, when there is when there's very little immunity, basically anyone who comes in contact with COVID-19 will in fact take it on, whether they're asymptomatic or not, and they're able to pass it to others. When we get to some immunity, you see that the chain begins to break a little bit, but there's still a fair amount of transmission. And then finally, when herd immunity takes hold, we break that chain and we don't get to zero transmissions, but we get closer to zero. We certainly get under 1. Now, so what are the expected consequences if we were, say, to halt completely our social distancing and all other precautions? And if we just let everything run rampant and drew the conclusion that we're willing to take on all the risk that exists? Well, if that would mean, again, using our assumptions, 68% of the population would get infected and the death rate would be 6.2 times the flu, or 0.56%. And you can see that here in the middle of the slide. That would mean over 1.25 million deaths. And then if you look at the extreme ranges of just varying one assumption, which is the population infected, in order to get to herd immunity, you can see the implication up as high as 1.5 million, or as low as just over 1 million would be infected. Now, the reality is this brief analysis ignores some really important factors that need to be considered by policymakers. It's no more than the beginnings of a framework to process through this. The death rate may go up significantly if the healthcare system cannot accommodate everyone with optimal treatment. If we don't have a number, if we, again, allowed there to be a surge, if we didn't have the right number of hospital beds, if we didn't have the right amount of ventilators, and more importantly, perhaps, or even more likely, at some point, our healthcare workers will not be able to sustain the pace that they're operating on. So if we had another quick surge on the heels of what we're in the middle of right now, it could tax the healthcare worker system, nurses and doctors who are on the front lines, to a degree that would perhaps significantly raise the death rate because of the inability to produce the optimal treatment. Again, the weakest link in the chain of care provided will be the determinant of that. Secondly, though, on the flip side, perhaps, the adjustment for underreported cases using the New York State preliminary results may not apply to the US. It may not be 10 times the number that are infected. Again, the more people that are infected today, given the death rate, that's actually good news. It means that the virus is less deadly. However, if we only have 3 million or 4 million true infections, not 9 million, that would mean the death rate is considerably higher. And then finally, to be fair to this analysis, we need to quantify the economic consequences resulting from all of the controls that we've put in place that are intending to limit and seemingly doing a reasonably good job of limiting the spread of COVID-19. So there's really 5 factors. Think of them as the metrics, the key metrics that represent the significant leverage points on this calculus of risk and balancing the virus with reopening the economy. And that is, 1, the widespread real-time test availability for the presence of COVID-19 on the ground, anyone who needs it, anyone who thinks they're symptomatic, and even those who don't. Secondly, we need a new, more effective treatment for COVID-19 patients. We're still learning about this virus and still trying to understand the implications of it. And we're learning that it has impact on sometimes the brain, on different organs throughout the body, not just on the pulmonary aspects or the lungs. Third point is the results of antibody testing. We need to be able to understand how close we are to reducing the rate of transmission because we have immunity. The fourth point is we need confidence that the presence of antibodies does in fact provide immunity. There's still some controversy over whether that's even true. And then finally, of course, a vaccine to reduce the risk of spreading COVID-19, even if people are exposed to it. So once we are able to get a handle on these 5 factors, we'll be much more informed about the decisions we need to make and be able to balance this calculus between reopening the economy and controlling the spread of the virus. But I think it's important to point out also that reopening the economy may do little to regain our economic footing as a country, because if the U.S. consumer lacks the confidence to participate, we're really not going to get the achieved result. If you open retail establishments and put some people back to work, that's not a silver bullet solution. I guess you could say on the supply side, there now would be the availability for people to go to shop and to buy things or to eat out at restaurants, et cetera. But if consumers don't patronize the establishments due to the fears of spreading the virus, business who have reopened will endure even greater economic hardship potentially. Think of a restaurant that opened up, called its workers back to work, put the utilities back on again, and in fact only got 20% of the revenue that they were experiencing when they were operating in a full economy. They may even be worse off than if they were actually closed. So that has to be considered as well. And in the end, I guess I would summarize it this way, that reopening the economy must be accompanied by consumer confidence. And I would suggest that consumer confidence is a function of 2 things. One, our collective belief and confidence in the leadership making decisions. And then finally, the transparency of the rational processes that these leaders employ to inform their decisions. So again, something for you to think about and process through, an example of how we work with our students to help develop their critical thinking skills.